Hello everyone, I'm Travis Holyk and I'm the Executive Director of Research, Primary Care and Strategic Services here at County Family Services. And Julie said that we're ahead of schedule so I can talk for an hour and a half. I wanted to start off by reiterating the CSFS mission, which is, with the guidance of our elders, County Family Services is committed to the healing and empowerment of First Nations families by taking direct responsibility for health, social, and legal services for First Nations people residing in Carrier and Sekani territory. And I think that's really important for us to remember, that this agency started with a group of elders who said children can't be removed from the community, that we need to start taking responsibility for the care of our children and for our family. And the idea that child welfare couldn't be stripped from other services, that Indigenous approach to wellness, where the health services and the child welfare services all needed to be together to make a holistic approach to health. I wanted to start off by talking about research, evaluation, and accreditation. Actually, accreditation will be at the end, but some of the services that we provide. So in 2005, so it's now been close to 15 years that we established our own research ethics policy and department to oversee research and evaluation. And really what we wanted to do was transform research into a path for healing and empowerment. So again, giving voice back to the communities around the issues that they wanted to see researched, and really direct benefit to the communities, because that's one of the things when we started, was that we heard that research wasn't directly benefiting the communities, that somebody would just come in, research, be gone, and that information was put on a shelf somewhere at UBC or UMBC, and they never knew what actually happened. So really one of the important things that we did was ensure that research has a direct benefit from the onset. Again, the importance of bringing voice for the community members is that everything that we do, and we get asked, how do you decide on the research projects that you are doing? We have a research review committee that's made up of members of all of the CSFS member nations. So we bring any potential research projects to that committee to make sure that the committee says, yes, this is important work and it needs to be done. And I also wanted to speak about how the research that we're doing benefits you. So again, it's research that's meaningful to the community. There's direct benefits. There's cross-cultural training. So there you can see a med student working with E.J. George from TACLA around our medical trust research. So they were able to teach each other a lot about the research process, about medical school. E.J. went into the university with the medical student and said, oh, this is actually something that I could do. So it's really important around building those relationships. Another really important piece, and I see Dr. Pat Camp is here, and thank you for coming, Dr. Camp. I'll speak a little bit about the lung health that we've been doing, but one of the things by having our own department and streamlining the process is that we've been really successful in applying for grants. I'm not going to throw out the numbers because I can't actually remember them right now, but I think it's around 15% of grants are typically awarded at CIHR, and CSFS, we're close to 100% on everything that we've applied for in the last few years. The other important thing is that research also leads to innovative programming. So as I go through some of the programs, a lot of them actually started as research, where the community said, this is what we need to do, and from that we were able to build on programs. I also, again, wanted to reiterate the importance of culture. So when we are doing research, most of the research that we do is actually focused on culture, so land-based activities when it is mental health or wellness, to make sure that culture is an integral part to the research process. The other important thing that both evaluation and research does is it enables us to develop our strategic plans around these issues. So as part of the strategic planning, when the communities say that suicide is an issue, that becomes an issue that we then target not just with research, but also with programming. So one of the projects that we've been doing since 2005 was focused on suicide. So we started with youth, and yeah, Sheldon. So I see, and it's pretty cool that Sheldon, Wyona, and Christine are here. They were some of the ones. I see Sheldon in the canoe right there in front of me. And so the land-based activities was taking people out on the land, and we then tested that as far as pre and post people's wellness. And so Sheldon always had to do those questionnaires kind of before we left and when we got completed the journey. So it's kind of cool that was probably, what, about 13 years ago, Sheldon? To now see how tall Sheldon is and how grown up they are, and also like the relationships that we built through those journeys. We then focused, oh, I hear some clapping, yeah. Then through feedback from communities, it was like, well, there's not just youth who potentially are victims of suicide. And so then we had another grant that focused on 25 to 45. And when we were doing that and putting out some of the training that we were doing on Facebook, some of the feedback to Marlena's crew was, well, how come it's only 25 to 45? So the exciting thing now is that we actually will be focused on an elder group. So when we talk about that holistic vision of health, we'll have manuals for every age group, and we'll really have a way of focusing on suicide throughout the age groups. And we just had our first advisory committee meeting to start off that group, and I see Sandra and others who are part of that advisory committee. I saw Nancy earlier, who's been a part of that work from the beginning as well. So acknowledging all the people who have been a big part of that work that we're doing. At one point, Dr. Henry Harder and I were invited to Notley with a focus on really around a cancer strategy, concerns about some of the mine tailings and other things. And that actually led to this project in particular, which was with Notley specifically around spiritual health. So when we had those meetings, one of the big things was that like all of these external forces putting pressure on the Notley community and what that does to an individual spirit. So we always want to be strengths-based. And so it was really Notley led. So even though I'm talking about it, it was one of those fantastic projects where Notley actually took the lead. And so around spirit, we talked about the importance of bringing spirit back to the community. After the fires, there was a fire ceremony to help heal the community. The community also said, well, we need the importance of taking people out on the land. So they did kayaking as part of the project. They also said, like, part of community spirit is doing something for one another. And so one of the things that Notley said, well, let's do, was they actually did firewood gathering. And that actually became really important because they gathered firewood before the fires, and then a lot of the trees were devastated. So the fact that they provided firewood to elders and some of the community members became much more important than we anticipated when we started that. And then with hunting, the idea again was getting out on the land. But the idea also was the importance of spirit, so doing ceremony before getting out on the land. And so again, like tying spirituality to a person's emotional wellness, but also getting out on the land, and also tying it to community spirit. And I already mentioned Pat. Part of what Notley also talked about was smoking cessation and some of the other issues related to cancer. And so we were fortunate that then Dr. Pat Camp approached us and said she was interested in doing research around lung health. Interestingly, when Pat and I first met with the advisory committee that I talked about, when we spoke about COPD, gave some introduction to what chronic obstructive pulmonary disease was, and then we spoke to community members and said, how many people in your community smoke? And everyone put up their hand. And then we said, how many people do you know have trouble getting up a flight of stairs? And everyone put up their hand. And then we said, okay, we're interested in doing COPD research. And the committee said, we don't have COPD in our community. And we said, whoa, back up. There's some other issues in the community that definitely get a lot more discussion, like cancer, like diabetes. I know Matthew's here, sorry Matthew, but and we said the reason that it may be an issue is that it's underreported. So in our electronic medical record, it was actually about 4% of people had COPD, and you can see that nationally it's usually about 12%. And so since that time, we've actually done spirometry on roughly 105 people. Spirometry, talk to Pat if you want more discussion of lung health. She's our expert. But it's when you blow into the sensor to then determine your lung capacity and lung function. So we've done that with 105 people. The committee said, we don't necessarily just want those individuals, because we did it as a random sample. We don't just necessarily want the random sample. We will also want individuals who come in to the clinic to be able to have this test. So we accommodated that. So we have a random sample so that we know the prevalence rates in our community, but we also have been testing anyone who wants to come in the communities. And shout out, we will be in Notley next week. And maybe Sycas, I still have to talk to Regina about that. And so right now, it's actually 17 out of 100 members of CSFS family from our random sample who have COPD. So that's 17%, which is actually higher than the national averages, just from us doing this type of research, where then we actually know what's happening in our communities. Again, cancer is an issue that community members bring up all the time. And so we have partnered with Dr. Shiona Mitchell-Foster from UNBC around women's health, and particularly focusing on HPV, so human papillomavirus. And one of the things that we heard from community is sometimes due to historic trauma, among other things, people don't necessarily want to go for a PAP. And so what this project actually does is allow women to do a self-screening swab where they do it themselves. We do have a kit outside if you're interested in looking at what that kit looks like. So for those who haven't had a PAP, you can actually do a self-swab, and then that is analyzed. It's actually put in the mail, and it's analyzed to actually see. And so we actually have had a couple of positive tests based on the work that we're doing. Really important, because cervical cancer, one of the major reasons for cervical cancer is HPV. I mentioned earlier that a lot of the research that we do actually leads into programming. And so our intensive therapeutic services, as well as family justice, started as research. So Mary and others, when they talk about us being around for a long time, the mediation services that we're able to provide started in around 2002 with the late Perry Shawana and others doing research around carrier ways of justice. And I know Julie Dom has been a mediator for a long time. That's been all part of this research that led into direct service delivery. And when we started that program, Julie, there were no First Nations mediators on the roster, I believe. And now, because of that program, how many would you say there are? At the peak 17. So again, a really successful program. I wanted to touch on as well with some of the research, it was really about prevention, but it was also about children remaining in their home, so not being removed from the care. Warner talked that 50% of children that are removed are Indigenous. So with our intensive family therapeutic services, it's a focus on children at imminent risk of removal. Since the program has started, we're actually, if you count all the way up to today, we're actually over 260 children. And with this program, 87% of children have remained with their parents. So I do a combination of cognitive behavior therapy as well as motivational interviewing, target with the families, intensely working with the families, and so making sure that children stay with those families with the right supports in place. And our family justice program is also preventative. It focuses on facilitating families in crisis or in need of support. So I do see Julia and Pauline at the back of the room. If you want more information about that program, by all means see them. Pat's waving too. See Pat for lung health, not for family justice. And so really, if there are disputes, family disputes in the community, we want to work with families before that actually gets to that crisis mode where children are removed. So with the Family Justice Program, they will come in and facilitate family meetings. They'll also work with youth who are needing supports in transitioning. I see Kathy Hemian there. Children who are in care, Kathy helps build plans for those children in care. And then another program that people wouldn't necessarily know that actually started as research is our primary care or our physician services. That in 2009, in partnership with the Northern Medical Program, we actually looked at trust of physicians, and the level of trust was really low. And so I think even Mabel tells me in the early days of Carey-Sicani County Family Services development, there was always a push to have our own physicians, but some of that research actually solidified that and gave us the tangible information to actually go to Northern Health and others and say, we need our own physician services for the communities. So, and then with the research talking about a low level of trust, the focus had to be on relationships as well as continuity of care. Continuity of care, now you'll actually hear the term primary care home. The idea is that you provide a wraparound service where people go to the same provider all the time. So our electronic medical record allows us to do that as well. In places like Takla, where it was previously a paper chart, when the physician or others were outside of the community, they didn't have access to the same information. Now, all of our providers have access to the same information at the same time. So it provides that almost like a house where all of your information is stored securely, where if you go to one of our providers, they have the same information. Our electronic medical record is essentially regional, and Northern Health and others are actually trying to figure out how to do that now because none of their electronic medical records talk to each other. So Carey-Sicani County Family Services is actually ahead of the game in the work that we've been doing. I mentioned primary care homes. So the idea that we now are working around services is really integrated service delivery. So again, that holistic model of care where it isn't just that you see one provider, that it's a team of providers that are providing the care that you need when you need it. So working with pharmacists and mental health, all having access to the same information to then provide care to the patients that we serve. At one point we had patient in the middle of that, and now we've actually switched what we're doing and we've put patient around the circle too, because we want to support our patients in being part of that care team too and making decisions on their own behalf about their care. So it's largely about a team of people coming together to provide the best care possible. And we've been really successful at this. It's now provincially they're talking about primary care homes. It's almost like the things that Carey-Sicani County does as trailblazers. Now the Ministry of Health is funding Doctors of BC to develop primary care homes that look a lot like this. As part of our evaluation process, one of the things that we looked at this year was around provider well-being. So I believe Marlena actually talked about the idea, I think it was Marlena, the idea of like basically change management, like how like as CSFS grows or even implements things like integrated care, how we make sure that it's not negatively impacting our workers, recruitment and retention. I guess with Regina following me too, that works. We want to make sure that our providers are happy and healthy so that they remain in the communities. So one of the things that we did look at is the impact of integrated care teams. So our providers did feel that the idea of ICT, or integrated care team, works well with their alignment of kind of that holistic approach to health. In those meetings, they feel heard and respected, that it is developing that sense of team, and that the input of all the team members is valued. So I think we're moving in the right direction. When we first started with the idea of integrated care teams, I think it was in around 2005, and everyone said, yes, it's a good idea, but how we actually got there was the challenge. So yes, it's a good idea, but no, I don't want to share my information because I fear confidentiality and I have to protect my clients, kind of was one of the things. So it was Sam who actually developed the terms of reference that says this is everyone's role, this is how we're protecting people's confidentiality. So a lot of work has gone into this, and we're really proud of the work we're doing. I also wanted to mention that we now have a medical clinic in Prince George. This has been really exciting that CSFS endeavored to again improve services for those who are off reserve, but also those who live in community and potentially come to Prince George for an extended period of time. And even during the fires, Sherry went out to the hotels and did a lot of service to community members who were in the hotels. And so just letting you know that at our 4th Avenue office, we do now have the Ubaya Clinic, which provides services to community members, again with that idea that it is a primary care home. So for those patients who move to Prince George and they don't have a physician, they're not attached to anyone, this provides the opportunity to actually have a provider that you go to on a regular basis. Again, that's just to show you so on the one side is what the electronic medical record looks like. On the other side is congratulations to our IT department. We have a large wide area network that keeps all the information safe and gets it to all of our communities and then back to CSFS. So it's just acknowledging all of the different things that we actually do around the care that we're providing to make sure that you get the best possible service. Warner touched on the idea of data-driven quality improvement. So Sam worked really hard with Matthew around really what are the key indicators of success. How do we know that the diabetes care that we're providing is actually making a difference? So he worked with Matthew on some of the indicators. There you can see where we're actually doing some work to see A1C levels in TACLA and whether or not we're actually seeing all the patients. We also worked with Pat, we haven't implemented it yet, around COPD and some of the best indicators to know whether or not we're making a difference in COPD. So we're hoping to ramp this up as we get someone who's a lot better in analytics to really drive the data that we have in our EMRs to make sure that we're providing the best care possible. And finally, we have accreditation. So under the direction of Warner, we wanted a process to ensure that the services that we're providing are at a high level, that all of our policies are in place. From the get-go, when accreditation came in, like policies around finance were second to none. Like I said, no changes there. They come in, they do an audit every 3 years of our programs, depending, like if you do as well as we did, then they come back every 3 years. That's the highest honor that you can actually get, and we did. So they bring providers from all over North America to come in and evaluate the services and make sure that the services that you're providing are at a particular level, that all of your policies are in place, that your documentation is sound, and again, we passed with the highest honor. This is the last slide that I have. I didn't really go an hour and a half. And so Kathy Scott meets with all of the teams under accreditation, meets with the managers first and says, okay, what are the things in a chart or in a file that would be important? And then from there, she audits to make sure that all of that information is in the chart. And of course, I picked an example where we're at 100%. In all of our programs, we're not necessarily 100%, but we're about continuous quality improvement, so we're trying to get there. But in some programs, it actually is like when we work through that our charting is impeccable. So with that, I'll say Snachaye.